So welcome back to this part 2 video on pleural effusions, where we're going to be talking about how to perform thoracocentesis. So there can be various indications for thoracocentesis, and this can include the acquisition of a diagnostic sample and depending on the size of the pleural effusion, also therapeutic drainage as well. And typically our aim here is to alleviate respiratory compromise, and this almost always means that we will want to drain the pleural effusion as fully as possible. There can be some exceptions to this rule. So for example, in a hemothorax, we would actually aim only to drain the effusion until the animal has got a relatively normal respiratory pattern. The reason for this is that blood will be reabsorbed and it can minimise the risk of us needing to give that patient a transfusion further down the line because they can reabsorb their own cells. Also, sometimes in a pneumothorax, if we fully drain a pneumothorax and the lungs are fully expanded, if there's a small defect in the periphery of the lung that's resulted in the pneumothorax, fully expanding the lungs can result in that ultimately starting to leak again. So we may go for a subcomplete drainage with a pneumothorax as well. And the other consideration as well is really chronic effusions, where the patient has had sort of essentially largely collapsed lung parenchyma for a long period of time. If we rapidly drain that effusion and we sort of very rapidly therefore expand the lung tissue that has been in a collapsed state for a long period of time, we can cause shear injury within the pulmonary parenchyma and result in sort of re-expansion pulmonary edema. So if we've got a really chronic effusion, we might drain it in parts as well to give the lungs time to gradually re-expand. Before we drain, we also always want to think, are there bicavity, so 2-cavity, or tricavity, 3-cavity effusions present also, because these can ultimately be related. So for example, a pericardial effusion would be expected to cause an abdominal effusion in both cats and dogs, and may also cause a pleural effusion in cats. So we need to be thinking about whether there is one effusion that's causative to the other effusions, or this may just indicate that there's a multi-systemic disease process going on that is affecting multiple cavities. The other consideration sometimes is that we find there's an effusion present, but there is not enough fluid to sample. So this can be, for example, where we're suspecting pathology. We'd actually find the effusion really helpful to analyse. We can see it on ultrasound. It's a tiny sliver. We can't sort of safely or accessibly get a sample. We might even have tried and not be able to. What we'll often find is, particularly if those patients have got a fluid deficit, by the time we have made them euhydrated, euvolemic, re-evaluating that effusion can be really helpful, because we may find it slightly greater in volume now and we're then able to sample it. The other thing to mention as well is times where we might consider effusions to be a normal finding, and we wouldn't normally ever expect to see any amount of pleural fluid in the chest on ultrasound in cats and dogs, but in the abdomen, in younger cats and dogs, it can be a normal finding to have a small volume of abdominal effusion. So when we talk about preparing for drainage, the time point at which we drain cats and dogs' chests with effusions is going to be variable depending on their clinical presentation. But for dyspneic patients, this is a life-saving measure that is usually done fairly promptly on arrival. Once we've done or provided some oxygen therapy, we've given them some anxiolysis, then actually the thing that is going to improve their dyspnea is draining that effusion as promptly as possible. So we're going to want to clip the chest adequately and perform a sterile surgical prep. And then the decision as to whether we require either sedation or anaesthesia is going to depend on the individual patient itself. Many of these patients tolerate needlepoint thoracocentesis, particularly if they've already had some anxiolysis, without requiring additional chemical restraint. However, if we're going to be thinking about needing additional chemical restraint because the patient's particularly anxious, it won't sort of sit still or tolerate the procedure, then what we're going to want to make sure is that we've got intubation kit available so that we can ventilate this patient if we need to. And often, if we've got respiratory compromise, then full anaesthesia is going to be safer than a sedation. So we just need to consider all of the patient factors in that, but certainly have intubation kit ready so that we can provide ventilatory support as needed. Then there's a discussion about whether or not we should use local anaesthetic in the chest wall to facilitate percutaneous thoracocentesis. In reality, a single fine sort of needle point is probably well tolerated by most patients, but we can consider a bleb of local anaesthetic such as lidocaine to facilitate the procedure if required. Ultimately, that requires a needle to go into the skin and partially into the chest wall as well. So there are pros and cons to doing that rather than just doing a single minimally invasive thoracentesis. If patients are coagulopathic, we might want to consider risks associated with that, although in reality, if they've got a large volume haemothorax, we're going to need to drain that anyway. But certainly evaluating for coagulopathy with our patient-side testing, so clotting times and platelet count, is going to help us move forwards with the diagnosis and treatment for those patients alongside the thoracentesis. If they've had trauma and could have a diaphragmatic rupture, then consider whether or not they could have abdominal organs in their chest. Your point of care ultrasound should let you know where you've got a safe window for drainage. And as previously, as we did in triage, when we're draining chests of patients with effusions, we will provide oxygen therapy to support their ventilation. From an equipment perspective, we want, as we've said, to sterilely clip and prep these patients. And then we'll want to use, depending on the size of the patient, sometimes we'll use a drape. So we'll certainly use a drape if we're doing any sort of chest drain placement. For needlepoint thoracentesis, we often have a big enough field that we can do a sterile prep without needing to use a sterile drape, but we can consider that, and we would certainly do that for drain placements. We'll want sterile gloves. We may well need anaesthetic or intubation equipment. As we've mentioned, we might need some lidocaine. And then there are various options available for materials to perform the thoracentesis. So these small butterfly needles that have got the extension line attached are really good for either small dogs or cats. And that extension line is really helpful to give us some flex as to having our sort of drainage syringe away from the body wall. For larger patients, often it's helpful to use a slightly longer needle. So for example, a 22 gauge, but sort of 1 inch or that sort of length needle, depending on the patient. And then attach that, for example, to an intravenous catheter extension set, just to give us, again, that same flex. So we're not having to attach our syringe directly to the needle. And we ultimately want to be able to either have a 3-way tap or a Y-piece connector to enable us to continuously drain without having to detach a syringe from the needle, because we will risk introducing a pneumothorax if that's the case. So we have to make some sort of closed system. At the bottom image on this screen is a Y connector that's valved. And basically, if we attach this to our needle that goes into the chest, or the extension line that's coming off the needle, then ultimately the valves in this piece of tubing enable us to have a syringe on one end. So the syringe goes on the end with the red clamp on, because we can aspirate on the syringe. Fluid will come out of the patient's chest up into the syringe, and then we can sort of expel the syringe, and because of the valves in the system, the fluid will come out the piece of tubing adjacent to the red clip. So this is really simple and effective, and a much easier process than using a 3-way tap. So I definitely recommend these, and we've got a video of us using one of these in a couple of slides time. We're going to want a syringe for collection, and then we're going to want our collection tubes for sending the fluid to the lab for analysis. And then we'll want a kidney dish as well, because the volume of fluid we'll get off these patients can be quite large at times. So in terms of our drainage site, this is largely going to depend whether we're performing our thoracentesis blind or ultrasound guided. So if we're going blind, we're going to go for fluid for between the 7th and 9th rib spaces in the ventral third of the chest, and sliding off the cranial aspect of the rib so that we avoid the neurovascular bundle on the caudal aspect of the rib. If we're draining air, then we're going to use the same spacing, but ultimately the dorsal third of the rib. We're going to want the patient in sternal recumbency, and as we've said, we're going to perform this using aseptic technique. So this video here is a demonstration of percutaneous thoracentesis using a butterfly needle that is connected to one of the valved Y drainage extensions in a small breed dog. So we count to between the 7th and 9th rib and slide off the cranial aspect of the rib in the ventral third of the chest. And you can either have your colleague count the rib spaces for you and point it out as we did in this video, or alternatively the picture at the top right of this slide, we've clipped a notch in this patient's fur at the 7th to the 9th rib, which is a visual aid that enables us to see exactly where that landmark is without the person who's doing the thoracentesis touching outside of the sterile field. The other thing that's not readily apparent in this video is that once you've got your needle into the chest wall, regardless of what needle type you're using, make sure that you flatten that off against the internal aspect of the chest wall. We don't want to leave the needle sticking perpendicularly into the chest wall because we'll risk lacerating the lung. So you can see the assistant in this video is helpfully sort of slowly aspirating the fluid out of the chest. Our first sets of samples went into the sample collection pots, and we'll talk about what pots to use in a second. But ultimately, the remainder of the fluid, once we've collected our diagnostic samples, is getting put into the kidney dish. So this technique works really nicely. The other thing is it's really important when you're aspirating on the chest contents with the syringe to not generate excessive negative pressure. So you want only a really small amount of negative pressure and a few air bubbles in the syringe. If you apply really excessive negative pressure, you're going to risk sort of sucking any sort of fronded material that's in the chest cavity into sort of the hub of your needle or the point of your needle and causing an obstruction. So do be careful not to use excessive negative pressure. So in terms of whether we should drain unilaterally or bilaterally, in theory, we shouldn't need to do bilateral drainage because in health, the mediastinum is incomplete. However, in severe inflammatory diseases, particularly where they're chronic, we can often find that fluid pockets and we can get sort of mediastinal thickening. And in reality, many of our patients will benefit from bilateral drainage. So we'll drain one side and then evaluate the other side and the patient's respiratory pattern and decide whether or not there's a clinical indication to drain the second side. In terms of potential complications, considerations will be sort of pneumothorax or hemorrhage. So if we're either lacerating the lung or sort of touching a structure in the chest that is vascularized, including the heart. We can also have re-expansion pulmonary edema. So we mentioned this previously when we spoke about sort of how rapidly or slowly to drain chests. In reality, in a patient that is presenting with acute dyspnea, the vast majority of the time it's appropriate to fully drain their chest, apart from, as we said, with the hemothorax or potentially the pneumothorax. Acute death due to either stress or lack of respiratory reserve, either due to patient stress, overzealous handling, or sedation without ventilatory support are real risks, which is why we want to minimise stress, provide oxygen, and if we are needing chemical restraint above sort of really mild chemical restraint, perhaps anaesthesia is safer and certainly have intubation kit available. And then sometimes we can be frustrated by a dry tap, and this can either be because we have not gone into the pleural cavity, either we've not gone far enough through the chest wall, we've gone all the way into the lung, we've touched another organ, or we've gone into some inflammatory material within the pleural cavity. So we want to reevaluate the pleural cavity with ultrasound, see if we want to use ultrasound guidance once we've identified a pocket, consider using a longer needle if we think that's been part of the problem. If the patient has not been perfectly still, consider whether or not we need to rethink chemical restraint. And then if they've got a really low volume effusion that is not causing a clinical concern, but ultimately you were sampling diagnostically, perhaps consider revisiting that in a day or so's time if you need to do it then if you've struggled the first time. So just one thing to say about ultrasound probe placement when we're draining effusion. So much of the time it's appropriate to do blind thoracocentesis at the landmarks we've described. It's also appropriate to do ultrasound guided thoracocentesis, and that can be anywhere we see an appropriate pocket. And if we're doing that, we need to make sure the alignment of our ultrasound probe matches up with our needle so that we're seeing the needle well into the field of view. So if we've got our ultrasound probe, so this is meant to be the footprint of the ultrasound probe, and we will see anything that appears in the midline of the ultrasound probe, which means that our needle has to go in perfectly in line with this midline and remain perfectly in line with the midline of the footprint of the ultrasound probe. So what we can't do is cross the midline, because we will perhaps see the needle for the small point it crosses the midline, but not anywhere else on the needle tract. And also, if we go parallel to the midline, we won't see our needle as well. So revisiting whether we've lined everything up appropriately, and if we need to, just gently moving the ultrasound probe to try and identify our needle, or if appropriate, reinserting the needle, will hopefully enable us to locate our needle.